All right, our next speaker is Dr. Das.
Hello, my name is Anup K. I'm a medical oncologist, a community medical oncologist practicing in Wheeling, West Virginia, not too far from OSU. So I thank Dr. Awad very much for inviting me here. And to Dr. Cook as well. It's a great privilege and a great pleasure. And I've never been to Africa before, and I was first here 3 days ago to get here. And within 3 days, I just feel very comfortable here, I must say. And so all the caribous that I've gotten from all of you, asante-san. So when Peter put me in the schedule to talk about systemic therapy of brain metastases, I said, okay, then I just have to get up here for a couple of minutes. We don't have anything very much. We rely on the surgeons, we have the radiation doctors, and that's it. Because systemic therapy, so I'm going to take this opportunity to talk a little about what the new targeted agents called precision medicine and personalized medicine, what this is all about, what the drugs, and where we go do this, with some reference to brain metastases, since these drugs can get much better into the brain than previous chemotherapy drugs, and also, much more excitingly, the new immune checkpoint inhibitors which I talk about. So the reason why we never had good systemic treatment for brain metastases or even chemotherapy for primary brain tumors, which I won't go over right now, is because of this thing called the blood-brain barrier. Now, the BBB is the ability of the brain to restrict movement of certain substances into and out of the brain. Now, the neurons, as you know better than I do, and all of you know, they're extremely sensitive, and no toxins, poisons, waste substances can get into the brain, because it would be disastrous. So it's a complex system of exchange, transport, and clearance. Hydrophilic, the substances just don't get in unless they're pulled in. Liquid-soluble substances will get in very easily, like alcohol, for instance. And this ensures the adequate concentration of essential compounds, oxygen, glucose, even glucose, which you know how much of glucose the brain uses, has to be taken in by a transport system. And at the same time protects the brain from toxic substances and glucose circulation. But this very thing that is good for our brains also prevents us from getting medications that will enter, that will cross the blood-brain barrier. So, just to show on a diagram what this thing just for reminding you. So, on the left we have a general capillary. So, when the capillaries become small, there are small openings in the endothelium for exchange of things to occur, and there's a small intercellular space. So things can leak in and leak out. But on the right, capillary the brain, it's got tight junctions. Because it can't let anything in, it doesn't want to, and it only has to let go when it really has to. So large macromolecules such as chemotherapy simply cannot cross this barrier. Most infections, very few antibiotics can. Infections usually can unless the blood-brain barrier is damaged, and so on and so forth. So there are many elements to this blood-brain barrier, including the fetal astrocytes, the pericytes, which pretty much cover up the blood vessel, but importantly, is called tight junctions versus not so tight junctions. Not so tight? Tight. Okay, so, no, sorry. So that is the blood-brain barrier. Now, you know, briefly, they're trying to find out ways to get medications into the brain, not just for cancer, brain metastases. Many of the major disorders such as Alzheimer's and Parkinson's disease and multiple sclerosis, we haven't found major drugs for this because of this. So now they work with nanotechnology and all that, but I just know briefly about that, but I won't talk about that right now. So what we're doing, so small molecules, if the molecule is greater than 600 Daltons, that's 60 kilograms, 600 volumes, that does not pass the blood-brain barrier. If it is lipid-soluble, it will pass easily. If it is small size and lipid-soluble, like temozolomide, it will quickly. Highly lipid-soluble alcohol, it passes quickly. Antibiotics, many do understand. So, for something to pass easily through the blood-brain barrier, medication-wise, it's a small molecule. Generally, anything less than 900 Daltons is considered a small molecule. But usually it has to be less than 600. For instance, temozolomide is only about 194. And if it's liposoluble, it passes through quickly. So, blood-brain barrier is compromised in pretty much any CNS tumors, encephalitis, multiple sclerosis, stroke. And tumors secrete a lot of VEGF. They have to make their own blood vessels. It is said that no tumor can grow metastatic or otherwise, no tumor can grow beyond 3 millimeters until it creates its own new blood vessels. The neuroangiogenesis is one of the hallmarks of cancers. So the reason sometimes some chemotherapy does get in is because the blood-brain barrier is damaged by the tumor. So once in a while we see responses, but not much. Okay, for metastatic cells to reach the brain, cross the blood-brain barrier and all that, the primary tumor gets access to the circulation in brain veins and lymph channels. However, you have cancer, and it grows, and all those cells, the tumors are stuck to this major parent cancer. Because if a tumor cell falls out, if it leaves the mothership, it's going to die. It cannot survive isolation. It must die. However, when it wants to metastasize, it has to do just the opposite. All the strong adhesion molecules like adherent, integrins and all, it has to just lose it so that it can come out. And of course, when it comes out, it's a hostile environment. These are outlaws. And evolution, nature, and the world, has not been made easy for them. But that's when we got the tumor microenvironment, which I just want to mention here because it will become very big over the next few years. This microenvironment is consisting of lymphocytes, of macrophages, of endothelial cells, fibroblasts, all kinds of the cancers not only turn these adversaries and hostile tissue to progressive, to enablers, to friend accomplices. For instance, even normal macrophages, right? Macrophages are best friends. But the cancer cells, the first stop that goes on, it must be very persuasive. They turn the macrophage from M1, which is what we generally think of, to something like M2 macrophages, which are inflammatory and help the cancer. Then fibroblasts, they produce cytocytic antigen. All the cells, including blood vessels, pericytes, adipocytes, and including the T cells, which are then driven off, and we'll talk about that when I look at the. Excuse me. Can I pass it on? So as the cancer cell comes out, or the body cancer goes to the tissues, we can think of that surrounding microenvironment as cancerized trauma. All these people are there to help the cancer cells now instead of block. For instance, there's a growth factor called TGF-beta, which is very anti-growth in the epithelium. It gives growth, so the epithelium doesn't grow too much. But out in the cancer cells, so they're not allowed to come out. If they do come out, however, TGF-beta, I asked you to be staying there. You're not supposed to come out. But since you come out, you showed me some initiative. So I'm going to have. So down check it and listen out. That's what they call that molecule. So, and like M1 macrophages, they become M2 macrophages. and start to kill the T cells which are come to attack the cancer cells. So once the cancer goes through the stroma, it develops this anyway, so let's go to it a little bit later. These are the cells, these are the cancers that most commonly go to the brain, but of course, pretty much any cancer can do that. Chemotherapy brain mets. One of the major challenges is the blood-brain barrier, tight junctions. There are two broad classes of drugs. One is liposoluble molecule, that is carmustine or mustine, and I am sorry, I have not given carmustine or mustine in a long time to anybody. They wake up some vague memories because horrendously myelosuppressive. And since primary brain tumors are pretty much treated at the universities, the university oncologists take care of that. We are, of course, very familiar with temozolomide, which is given as an adjuvant for glioblastoma multiforme and so on and so forth. We are, of course, very familiar with avastin, which is a vascular endothelial growth factor receptor inhibitor. So, in the last evidence you can see, small molecules, approximately 500 kilodalton, small molecules are temozolomide and lenvatinib, alatinib. So, any of the IMPs are tyrosine kinase inhibitors, which I've shown you. So, this is something also that plays a major role. In when we're embryos, the cells travel from one place to another to make new tissues. They become from epithelial cells to mesenchymal cells, TME, and then go on somewhere else and become epithelial cells again. Only stem cells can do that. And the cancer cells are found that way. That's what they can creep through the tissue, get into a blood vessel, and once in the blood vessel, they take off, but they protect themselves with the travel numbers, cover themselves with platelets. Maybe that's why we thrombose. And then when they come to the right place with homing signalers, nobody knows quite yet what that is, but then they will enter the tissue and become a metastatic site. So these things have pathways like hedgehog, twist, snake. Anyway, but that's a very important property of embryonic stem cells, and the cancer cells just become like that. That's why people are talking so much about cancer stem cells. Okay, so now we come to targeted treatment. Proton Oncogy is a good guy on the left, but he's a gene that, if mutated, can become a cancer gene, oncogene. Now, now, he's a very important guy. He's a department head, he's a leader, he meets with other department heads every day, because if one of the lesser genes, housekeeper genes, is important, but if they get mutated, we can survive the consequences. It won't mean that much. But if the leader of the team, of the general, of the department head turns traitor, then we're in big trouble. So all proton oncogenes are very important genes for cell growth, differentiation, motility, whatever that life needs. So that is why when they become corrupted or mutated, it is so dangerous. So we call him KRAS for the time being, because that's a very important oncogene. So when it becomes mutated, it becomes an oncogene. So proton oncogene gets a mutation, becomes an oncogene, which then gets 1, 2, 3, 4, 5, 6, 7, 8, 10 mutations, and with each mutation, the cell is pushed more towards malignancy, until finally it becomes primary malignant. Okay, so this is so for signaling purposes, something happens outside the cell. It wants something needs the cell to do something, make a protein, something. The signal has to come. First of all, the cell has to receive the signal. So right there, So right there, that's the receptor. And it's got an extracellular bond, intercellular bond. So growth factor comes in and attaches to this, and the signal is sent, and the bottom part of the tyrosine kinase receptors, and so they automatically phosphatate at the phosphorus group. So as you know, ATP is the currency of energy. So once that phosphate is added, it forms a kind of adapters to this oncogene, which can they start signaling each other. The phosphate group is set up here, then to this, to Earth, and finally to the nucleus, where it becomes a transcription factor and helps transcribe a gene that is needed for that particular protein. So the phosphate group, and then I'm not a chemist, biochemist, or molecular biologist, but the third phosphate group of ATP is like a set of springs. So each one of these cascade of events through the cytoplasm is transferring the phosphate group from one to another, from RAS to RAF, RAF to MEG, MEG to ERG, and so on and so forth. So think about something, just go ahead and switch off, switch on, switch on, switch on. Remember that in the mutated gene, that switch is not going to be turned off. With the normal RAS gene, that switch after the job has been done will get turned off, so that growth of whatever stops. Or I'd like to think of it as relay race. That phosphate group, it's a very energizing thing. Just goes into one relay runner, it takes it like a baton, gives it to next, gives it to next, until a transcription factor is produced, which finally, causes a whatever gene to be transcribed to make whatever workhorse protein that is needed at that time. The mechanisms for turning off the switch are many, but in a mutated oncogene, it can have a subset form. For instance, that area, this RAS, is supposed to take the GTP back to GTP. So it's now turned into GTP because activated. So now it's supposed to take it back. But RAS is mutated, so it cannot do so. So the signal is turned on, and there is no off switch. So there's just relentless signaling. So these are the targets. We have a drug for metastatic melanoma against RAF, against MEG. We have certainly, but KRAS is one that we have got medication against it. So any of these can be good targets. So the epidermal growth factor receptor, that's a very major receptor for a lot of ligands can come in. These are all separate pathways, but all interconnect. Ultimately, they grow the cell and transcribe some factor, proliferation, survival, angiogenesis, migration, escape the immune system, escape apoptosis, and that is cancer. So there are, however, even if we have an abnormal mutated oncogene, it has to be a driver mutation. At any particular time in cancer growth, there is the mutation that is driving it is called the driver mutation. There are other mutations that are present there, but they're not driving it at that time. So in other words, the cell cycle was repaired, nothing happens, normal, but it's slightly mutated, then one mutates, this is the bad one, these are quiescent, and this goes on to form a tumor. Myeloma probably become leiomyosarcoma. Now, I saw this a long time ago, somebody's lecture, and but it really impressed me. So I spent about 2 hours looking for this sucker. Okay, and this really explains what it is. This is a spider, of course. You recognize it. It's got 4 legs. This side 4 legs, that side. Phylum Arthropoda class, I think. And if I put 3 legs there, the spider would be after me. The spiders have 8 legs, not 6. Insects have 6 legs. So now all these mutations have normal pathways, but they're quiet. This is the driver mutation. So if you have a drug that cuts this one off, spider doesn't care. Have a drug that cuts this one off, spider doesn't care. But if you get the driver mutation cut off here, then the spider will have to fall. Now ultimately it's going to get back up and use another pathway, which will then become the driver mutation. But if that takes 1, 2, 3 years with a little bit of luck, then we have done the patient some good. Because most of these are small molecules, they're oral medication, they're just pills, and the side effects are there, but of course usually much less than chemotherapy. But ultimately, the spider will find a way to grow again through another mutation. But hopefully, we'll have another drug at that time. So the driver mutation concept is extremely important. And the second thing is you'll have a driver mutation, but you won't get cancer because the driver mutation is like the switch is turned on, the gas pedal is stuck up to the floor. But nothing's going to happen if the brakes are on. Now that's where the tumor suppressor genes come in. So they have to be inactivated as well. So ultimately, when they are inactivated and the active oncogene inactive tumor suppressor, because there's a recessive, there has to be 2 brakes here, and no brakes, gas pedal stuck to the floor, crashes. So that's what it gets. The cells just keep going. So that's a common slide that people show in oncology. Again, tumor suppressor genes act like brake pedal. It can act at any one of those. Initially, whether the growth signal receptor with the message is received through that cascade of signaling in the cytoplasm, or even within the cell. Now, our major tumor suppressor gene, but the most important one, is P53. As a matter of fact, P53 is the last event that's knocking out P53, the last event that occurs before cancer really, before malignancy. So you may have lots of mutation, but you really have to turn off this off usually. So various environmental factors will influence that. Cells with minor damage, P53 makes sure they are repaired because it commands the DNA damage response team. So cell activity is halted, the repair takes place, and the cells are repaired and they are allowed to go into the rest of the cell cycles. Very damaged cells, they have to undergo apoptosis. That's how it protects the whole genome. So it's called the guardian of the genome because it has many activities and meshes with a lot of stuff. So the oncogene has to be turned on, the active oncogene has to turn on the gene at its promoter region. And since it's a very important gene, and it becomes an oncogene which is against the gene, but that won't progress to cancer unless we turn this one off. Now, for a long time, it was known that elephants didn't get cancer. And it was only recently, in the last few months, that they found out why. And that was because elephants have 20 P53 genes and we have just one time. So, just by the way. So we have a lot of drugs nowadays, these targeted agents. They go through whatever mutation. We find a mutation, we find a target drug for it. For lung cancer like EGFR, ALK1, a bunch of them. This is only until 2006. There are a whole number of new ones, and the list has grown. But the two major disadvantages about these tyrosine kinase inhibitors are that one is, of course, it's extremely expensive, like most of our new cancer therapy is. And the second one is that the mutated ASO driver mutation that we can find are relatively few. Non-metastatic advanced non-small cell lung cancer, for instance. You get the EGFR mutation at really less than 10%, depending on the area. And another one called anaplastic lymphoma kinase mutate only in 2% of patients. So we check for this mutation. We find it, then instead of giving chemotherapy, we can give a pill. But second, the other thing is that they develop new mutations, new driver mutations, and so at about approximately a year or so, most of them will progress. And of course, they're extraordinarily expensive. Gleevec was the first one, and that was a home run and a touchdown and a last minute goal for the hematology and oncology profession. We get only a few basics once in a while, but based on that, they've manufactured home runs. So these are the toxicities of these things. Most of them will cause skin rash, diarrhea, mucositis, some nausea, vomiting, and all that. It tends to go away after a couple of months. That's of course the VEGF, Avastin, bevacizumab, and people do tolerate it very well. Nothing happens. If something happens, I get it out of town because it's perforation, major bleeding, that you can't stop that kind of thing. But it's a very useful drug and we employ it now. So, all right. Now we come to the immune checkpoint inhibitors. Now, we've all thought and we've all known that the immune system is a complex organ which has developed throughout evolution for billions, hundreds of billions of years, and it has many branches. And it's the same even in primitive animals, maybe even in Luca, who's the her last universal common ancestor, which was a cell with the phospholipid membrane, some DNA, some RNA, triplet codon, and all that we all came from. So I don't know whether rats and mink and all that go back all the way there. But the immune system has developed, as we know, to prevent infection and to take care of infections if we do. So if we didn't have an immune system, all of us, most of us would be in ICU with sepsis, right? Or something like that. Now, the question was that why didn't nature or evolution or the good Lord give us something to prevent these abnormal outlaw cells from becoming cancerous? Well, it so happens that they do. Paul earlier said that if we didn't have an immune system 100 years ago, that we would everyone would be getting major cancer. And this was not really believed, it was a hotly debated topic until only about 10-15 years ago. And our new checkpoint inhibitors that we've already pretty much changed to immunotherapy from, at least we try to, from chemotherapy whenever we can. So the ones that Keytruda, pembrolizumab, Opdivo that you see, certainly an American TV and all that, these are immune checkpoint inhibitors. They're much easier to take, much less toxic. So what happens is, and this also happens in infection, inflammation. There's a B cell, and this is an abnormal cell, a cancer cell or an inflammatory cell, which is out to do damage. This cell must be recognized by the antigen presenting cell, usually a dendritic cell, and that MHC complex, which all nucleated cells must have to be identified, the APC exposes that to the T cell. So it's like a barcode. So this peptide is a barcode for this cancer cell, which has been engulfed by the APC. Once that happens, these T cells are running around trying to find a new barcode to attach to. They are naive T cells. So as soon as they see it, the T cell receptor goes and attaches. That's signal one. That is essential before this T cell can harm this cancer cell. But that's not enough. Then there has to be signal 2 in which CD28, a receptor on the T cell, attaches to B7, a receptor on the APC and Q cell. Once that happens, then it falls together all the cytokines, the granzyme, the perforins, whatever, to come and cascade on this and break it apart. If signal 1 happens and signal 2 does not happen, it's not going to work. So the same thing goes to inflammation. If I have an infection on my heart, it's going to get red, it's going to get hard, it's going to get painful, tender. But once the infection is being taken care of, the inflammatory system has to retreat, because I don't want it to go and eat up my whole heart. So these are the 2 checkpoints that prevent the immune system from going too far. So this activates it, but this one is the one that is going to come in. So when you have this one now, CTLA4 comes and attaches to B7, it's 20 times more stronger attachment to that, so the immune system gets turned on. Here's another one where we have common drugs now. It's called program death receptor 1. I don't know why they call it, it's not the program death receptor, but anyway. And that's the program death receptor ligand. These are both inhibitory things. If we to push the immune system back, if we take off this with the drugs, with the inhibitors, the immune system is allowed to proceed further and kill this stuff. So that's the whole idea of immune checkpoint inhibitors. What we're doing is, sometimes I tell patients like this, that we have this 800-pound gorilla which has evolved over the years, over the billions, millions of years, as our immune system, and it can attack viruses, bacteria, etc. within 10 yards. But then it has 2 checkpoints that prevent it from going further. And the cancer cells have escaped the immune system. They do have their barcode, they're recognizable, but they're floating around at 1.5 feet. So they can't get to it. We just take out the checkpoints. So the stop sign is there, the bar, the stop sign goes up, and the invading army goes in. It was thought that human beings could tolerate it. As a matter of fact, a researcher from Berkeley once, I was listening to, said that initial experiments, they gave animals the tumors, mice, and knocked out CTLA4, and let these cells go. So they found the animals, the tumors were gone, but the animals were not recognizable because they were just like big lymph nodes with these cells. So, but after making the dosage and all that, here now, people in reality are tolerating beautifully. So the last 2 years of between 2 or 3 years that we're giving this, now probably we're giving immunotherapy 50%, chemotherapy another 50%. And people think that the days of chemo are over. I'm sure it's not that simple, but yes, people come in, no pre-medication needed, and most of them tolerate it. They just go home, they don't take anything. One of the hallmarks of immunotherapy is that if there's a response, that's what happens. These T cells, once they recognize that, and there's a second signal comes in, half of them go to destroy the cancer cell. The other half becomes memory effector cells, just like these cells after vaccination. So even if you miss a couple of doses, if you stop, then it keeps on working because these cells are left behind, and the children's children have the memory of that workload, and they will keep on working. So long-term response, very little long-term resistance. Is once if it works, it's going to work long time, usually. I'm missing the slides now. Sure. So this is just a list of immune checkpoint inhibitors and the conditions that we are treating nowadays routinely. Metastatic melanoma. Now, of course, melanoma is a disease of fair-skinned people, but it's a significant cancer. And if it's superficial and it's cut out, nothing the patient will live on to 100 years old without any problem. But if it metastasizes prior to 2011, there was nothing we could do. I mean, the chemotherapy that we gave was, the crime was pretty bad, but the punishment was worse. I hated giving that. But then the first one came out, the anti-CTLA antibody, that was started out to be given in 2011. That is a toxic one. So we give only 4 doses, one week apart, so over one. And it said that about 50 or 60% of those patients are alive and well without any evidence of disease. And this is metastatic melanoma, which was a death sentence in 3 to 6 months, and sometimes even worse because it could metastasis to all kinds of places, nothing you could do about it. But those people are doing magnificently. So that's the first one, AP for sure. Then we have Nivo, which is much easily tolerated, so non-small cell lung cancer. This is all advanced disease. Kidney cancer, hepatocellular carcinoma, squamous cell carcinoma, carcinoma, head, neck, urothelial cancer, colorectal cancer, certain ones, and there are others. So every drug company wants to find an immune checkpoint inhibitor or a kinase inhibitor. So toxicities of immune checkpoint inhibitor, any organ you take off and you add itis, it can cause that. Dermatitis, hepatitis, colitis, and things like hypophysitis, which took me a little while to learn how to spell, but thyroiditis, iritis, you name myocarditis. So, but however, serious grade 3, grade 4 toxicities are less than a few percent, and fatal toxicity is less than 2%. So obviously, hypophysitis would be serious. Myocarditis would be serious, but it's hard to recognize these things. So what happens is that, let's say, a pneumonitis, for instance, so what happens, somebody has non-small cell lung cancer, he has cough and all that, and he has a increased cough, maybe even a little temperature, goes into the emergency room and has a chest x-ray, and they say everybody's got an infiltrate. I mean, you can say that, pneumonitis from these drugs is less than 2%, so these people commonly get those symptoms. So anyway, so it's hard to recognize them. At the same time, if you don't recognize them right away and start high-dose steroids to back the immune system up, the mortality is almost very high. So all of us are beginning to recognize those things. We monitor the device and thyroid functions and all that. But what I'd like to say that excepting for those few instances, I haven't had a fatality yet of the last 2 years, and we treated about 30 to 50 IV agents in every day in the office. Half of them chemo, half of them immune checkpoint inhibitors. That's a dermatitis rash, thyroid function dysfunction, and I'm not really sure I had a severe colitis. But again, diarrhea is a common system, so we want to be careful not to miss it. Because then we have to put the patient high-dose steroids right away, and if it's grade 3 or grade 4, we don't dare to give it again. But on the whole, if the patient the response rates are not as high as we'd like to think, because they're still about 30%, maybe 40%. Some companies will say higher, but things may not work the way it should. For instance, the T-cell receptor recognizes the MHC complex of the tumor cell of the barcode, and then it has to grow, make at least the cells are at least 1,000 of them, but the cancer cell is equally small, and we just put it in its barcode and hide it inside. And so that when they come back, what the heck does this guy go? That sort of thing. So anyway, so these results, honestly, we would never have even imagined. This is a combination of Evo and Ipi for metastatic melanoma, and 60% of the, this is out of 27 months, and now it's actually gone on after here. These people are supposed to do well for the longest time, if they even cure. Combine the volume and metastatic to the brain, because tyrosine kinase inhibitors, monoclonal antibodies, immune checkpoint, the drug may not get in, but the activated T cell does get into the brain. So the previous slide showed that the response of metastasis to brain as well as systemic was pretty much equal, and these patients now 70-80% of them are living fine and not even getting treated anymore. So, and this shows the intracranial overall response rate 55%. 21% of them actually is achieving complete remission, long-term remission, even within the brain. And medium survival is not able to reach. This has gone out. So, those graphs that we used to have for cancer and came out like this, and like different separation and the table drop. Now we do have graphs going like this. So just because we can check on inhibitors. So it's very gratifying. Close to 20,000 patients studied retrospectively. Fatality rate 0.36%. Little bit more with the anti-serial 1.123%, and very small fatality rates. That's grade 3, grade 4 toxicity also very low rate. This I just want to put up there because this is a Russell Park Cancer Institute where I did my fellowship in Buffalo, and I just want to show you that. Especially, I wanted to show Dr. Russell Park, who said Russell Park Cancer Institute was the first true cancer institute, the first institute dedicated to research, study, and treatment of cancer. It opened in 1898, and then came all the other cancer institutes. He was, and also I want to mention that he was a pioneer neurosurgeon by training. Although he did no cancer surgery, or spinal surgery I think was his forte, but he did other surgeries. And the other thing was that he was one of the people that really pushed infection control. I think it was Joseph Lister in 1876 said that dump ethylene acid, and he pushed that further so that his infections were much longer. And he also founded the first real cancer institute. And that's my last slide. This is the 5 years after the institute opened. So William Osler founded the Johns Hopkins Hospital, wrote it on the part. It's surprising how little systematic work has been done on cancer that has been undertaken in this country so far. The only laboratory devoted to it is SPU and supported by New York State company. So I've always considered him to be a big hero of mine. In fact, that he was a neurosurgeon, I thought would be interesting for you. So thank you very much.
All right.
And the last thing I wanted to say was, these things are extraordinarily expensive, of course, but if we did manage to get immunotherapy, then people don't get sick. They go, they get their current for 2 hours, no pre-medical, get the infusion, and nowadays instead of every 2 or 3 weeks, start trying to make it every 4 weeks to every 6 weeks. The disease remains in control sometimes, even after you take them off the drug long term. So that's what everyone is hoping that we're heading towards. But I can't do anything about big pharma and the expense of the drugs, that's for sure.
Thank you so much,
Sure.
Dr. Dutt.